thank you very much for your introduction. I was asked to give a brief introduction on the hyperthermia devices currently at use in various clinics. And in this presentation, I will interpret hyperthermia as the mild hyperthermia regime using temperatures well below 45 degrees centigrade. So the kind of hyperthermia where we aim at the synergy between the hyperthermia, radiotherapy, and/or chemotherapy. So as the previous presentation already outlined very clearly, in many for many tumor sites, the results of adding hyperthermia to standard radiotherapy or chemotherapy have been quite good. And this slide shows, for instance, a meta-analysis published 4 years ago by the previous speaker. So I'd like to begin by distinguishing 4 different heating strategies. First of all, the local external techniques, both radiative and capacitive heating techniques. Then the local invasive techniques, so where actually the heat source is implanted into the body of the patient. Then there are perfusional techniques, mainly using heart-lung machines in order to heat up a part of the body. And finally, whole body hyperthermia, which was actually one of the first forms of hyperthermia to be widely used in the clinic now 30, 40 years ago. Starting with the radiative techniques, the first category is for superficial tumors, so where you actually heat a tumor which is very close to the skin. For this category of tumors, there have been quite a number of positive trials. Mentioning here first a meta-analysis by Vernon et al. From 1996, and melanoma by Overgaard in 1995. So these techniques use one or more antennas directed directly at the tumor. And like I said at the beginning, the penetration depth of the equipment used allows you to heat tumors up to, let's say, 4 centimeters at depth. And for the various depths, you can use different types of equipment. For the microwave and radio frequency techniques shown here, normally you would need to perform these treatments within a room which is shielded, so that you, the outside world cannot see the radiation you're using, so to avoid disturbance of equipment around. But the frequencies used by the main forms of equipment are chosen such that you can do this in a room without any shielding. And the last 2 techniques are presently the 2 most commonly used techniques. And these include heating devices like the BSD 500 system by Parexar, which can use both waveguides and spiral antennas and arrays of spiral antennas. An in-house developed system from Erasmus MC is using a lucite cone applicator, which has the advantage that it has a very good effective field size, which allows you to use it also in arrays of applicators. And you have to notice here that in order to give a good treatment, you will need to place a bag of water, which we normally refer to as a water bolus, between the antenna or applicator and the skin of the patient, because otherwise part of the energy emitted by the antenna is reflected on the skin, which makes, first of all, the treatment less efficient, but also you will get a very heterogeneous heating by that. You can also use contact flexible microchip applicators. These were developed during the 1990s. The advantage of these is that they are bendable and they come in different sizes. And this is what the different heating patterns look like. And the interesting thing is that if you bend them, you can also increase the penetration depth, but let's say slightly. The bending is mainly intended to make the applicator form follow the form of the body of the patient. And these are some examples of the use of these. Of course, during treatment, you also need to verify what is the temperature distribution you are achieving. This is normally done with thermometry probes, which can be of various types and which can be stationary on the body or be moved during treatment to cover a larger treatment area. And here are some examples of the way we're doing it at our institute. So we have multiple multi-sensor applicators on the target area, which more or less map the entire distribution. And in addition to that, we also, if possible, if the tumor is reaching quite deeply, we're also having invasive probes, which are located, for instance, under the scar tissue or at other prime locations. And after we've mounted the thermometry, we put on the applicator for the treatment. Commercial equipment, this is the Alba 4000 system. This uses the same type of microchip antennas, but then in a fixed curvature, in 4 different sizes. And they also permit the use of multiple antennas at the same time. If the tumor is not as deep reaching, then you could also use an infrared system. We use this equipment mainly for very large tumor areas, the so-called cancer en cuirasse. And instead of electromagnetic waves, in this case infrared radiation is used, with a special filtering to increase the effective heating depth. And this is what it looks like during treatment. So in this case, no water bag between the patient and the applicator, which also means that you can use an infrared camera to actually monitor the temperature distribution during treatment. For deep-seated tumors, we can use electromagnetic applicators as well, but in this case it is arranged in a ring of applicators around the patient. These have been used in a number of positive clinical trials for cervical cancer, rectal cancer, and sarcoma, for instance. And the frequency in this case is way lower than for the superficial systems in order to achieve a better and deeper penetration of the radiation. And then again, one antenna is not sufficient. You really need a number of antennas around the patient in order to reach that sort of depth. In this case, we are also using a bag with water between the antenna and the skin of the patient. But for the superficial tumors, the water is heated in order to get a good tumor temperature. Here the skin is not a target region, so we actually cool the skin, and we utilize this water circulating in these water bags. The steering is achieved by phase and amplitude control, which basically means that we can vary the phase of the individual antennas, and by doing so we can move the focal area in the patient to basically any designated subvolume. In patients, you will see that the sort of distribution you get is heterogeneous because the power absorption will vary depending on the tissue type. So, for instance, in high water content tissues like muscle, you will see a way higher absorption than in low water content tissues like, for instance, fat. And examples of clinical systems, again, one of the first BSD systems, the Sigma 60, with 8 dipole antennas, and the first version with a single ring, which was then partially replaced with a system capable of 3D steering of the SAR focus by having multiple rings of antennas. The Sigma I uses 24 dipole antennas. At our institute, we had our in-house developed system, the AMC H system, using 2 rings with in total 8 waveguides, and we can also use that as a single ring if the patient is very well, not very long. Then 2 rings is way too much for those patients. There is now recent, last year, the Alba 4D system came on the market, which is basically 1 ring of the AMC H system. And with regional hyperthermia, you of course also need to verify what the temperature is. That was traditionally done by a minimally invasive thermometry, so minimally referring to the fact that you're utilizing already existing cavities in the patient in order to put in thermometry probes, so like bladder, rectum, and if applicable, vagina. And this has also been supplemented with the option to use non-invasive thermometry using MRI. And then you get this kind of distributions where you can see that you can verify the region where the temperature has reached therapeutic levels. You can also see that the heating area is fairly large, which also means that you get a fairly homogeneous distribution within that area. Another system currently in use at Erasmus MC in Rotterdam is a dedicated system for head and neck tumors, which I have to verify whether this is the present configuration, but it is using patch antennas at 434 megahertz. And this is actually what the first version looked like, which in this case is also very instructive in showing you what the treatment will be like for the patient. And this is for a head and neck tumor, can also be used higher in the head for head and neck tumors, let's say just underneath the brain or those areas. The same can also be used with capacitive systems. So there have been positive clinical trials for those. The most recent one was the one for head and neck tumors by Hilgol. And basically these systems use 2 electrodes which are used at either side of the body. And you can steer the heating location by the placement location of your electrodes, but also the size of the electrodes. So if you use equally sized electrodes, you get heating more or less centrally in the body, whereas if you use a larger and a smaller electrode, then the heating will tend to focalize underneath the smaller electrode. So some examples of systems. This was the first one that came on the market from Japan, but there are also a number of other vendors also represented here, by the way. For superficial tumors, this is likely to work quite well. The main concern can be if you're heating, trying to heat a very deep-seated tumor in a fairly obese patient, then you have an increased risk of having fat heating. So you get absorption in the fat layer. This is shown here for a homogeneous phantom, but for patients you could see the same sort of issue. And we can see that if the patient has a fairly small or an absence of fat layers, then this heating will work well. For instance, if you would be treating, for instance, pancreatic cancer, those patients are usually without a fat layer, and that would go quite well also because the pancreas is not centrally located but more towards the surface of the body. So invasive techniques, this is actually what has been done at a quite large scale for bladder cancers, for non-muscle invasive bladder cancer. The first device used there was utilizing a 915 megahertz microwave antenna, which is inserted into the bladder and which will locally heat the bladder wall. More recently, I have to say, a more simplistic form of heating came to the market, where a fluid containing chemotherapy is circulating through the actively circulating through the bladder using a pump system, and the results of those are currently awaited. So another class is where the heating needles are actually inserted into the body, and this is a technique which is comparable to brachytherapy used in radiotherapy. So it is actually very often using the same implant as for brachytherapy. And the main locations where it is used are prostate, head and neck, and brain, which are basically the sort of sites where people are using brachytherapy as well. And to this end, one can use the BSD 500 system, which is also using a 915 megahertz applicator. And it allows an implant of up to 24 applicators, so this will be sufficient to cover actually a normal brachytherapy implant. And it also allows you to use it both in a synchronous and a non-synchronous way. And this will permit steering of the absorption and the heating within the implant region. And here an example of what an implant looks like. This is of course a more superficially located tumor. A system which I helped to develop earlier on was the multi-electrode current source system. This actually uses not a radiative but a capacitively coupled current source system with multiple electrodes per applicator. In this case, in this schematic view, just 2, but we developed up to 4 per applicator. And where the thermometry consisted of a thermometry probe inserted within the applicator. And we also tested, of course, whether this could be used with completely independent electrodes on a single applicator, and we found that we could actually steer and control the temperature distribution along a single applicator and also within an applicator array. So the electrodes are independent, and that means you have spatial control within your implant volume. And this is what it looked like, for instance, in an implant for a brain tumor. But when we applied this, we also found that in brain tumors, perfusion levels are so high that it is, even with a dense spacing of electrodes, it's fairly difficult to get a good temperature distribution within that brain tumors. Although survival of the patients treated with those methods was longer than expected, but the numbers were fairly low, so conclusions cannot be drawn. Perfusion techniques. These are, of course, a logical idea if the tumor is located in a limb, for instance, and if the chemotherapy of choice can cause serious systemic toxicity. In that case, an isolated perfusion is a logical option. So you can then even increase the dosage to the limb and to the tumor without serious systemic toxicity. So there have been positive clinical trials for soft tissue sarcomas located in the limbs. And the main advantage is that the concentration of drugs in the tumor is way higher than what you normally have with a normal systemic application of chemotherapy. So how does one do this? This actually involves the use of already existing equipment in operating theaters. So you clamp and cannulate the major artery and vein, and you use a heart-lung machine to actually have the isolated perfusion of your extremity. And so all of these do not really require the involvement of major manufacturers. And this is what it looks like to control these treatments. And then, as the previous speaker already outlined when he was performing his meta-analysis of hyperthermia, that actually most of the recent trials are not the forms of hyperthermia I've discussed so far, but are involving HIPEC, which means that you circulate a fluid containing chemotherapy in the peritoneal cavity, and you do this in order to get rid of metastasis in that region. This is only intended for microscopic disease, so this is performed after surgery to remove the macroscopic tumors, which means that the nodules left are, let's say, order size order of a millimeter or smaller. There have been a number of positive trials, both for metastasis of colorectal origin and ovarian origin. And the form of HIPEC can be either an open technique, which allows the surgeon to actually correct heterogeneities during the execution of treatment by hand, or a closed technique where you simply have one inflow and one outflow from the cavity. So these are then all the ingredients needed, where the part of the concerns are that you try to, at one hand, to have a simple form of circulation, but you also want to prevent chemotherapy to evaporate into the operating theater. You want to have a homogeneous temperature distribution in your target region, and you want to monitor that. So normally a limited number of temperature probes are within the cavity, but that is sufficient to actually monitor the distribution. And if we look at the systems available, there are a number of them currently in use, and some of the mainly used systems are shown here. The Thermochem 2000, also Combat, who's also supplying equipment for heating bladder cancer, has a special system developed for HIPEC, where they also add a form of agitation to further homogenize the temperature distribution during HIPEC, which is normally performed by the surgeons by shaking the patient or by manual manipulation during treatment. And this is then the kind of distributions one can get if you make certain that you get a homogeneous flow and temperature distribution. So the whole body hyperthermia This is, of course, from a physics point of view, one of the more simple techniques. But of course, a main limitation is that you cannot possibly raise the temperature higher than 42 degrees centigrade. It's normally used in combination with chemotherapy, and it's applied for metastatic disease. Patients, if you go to this very high temperature, are under sedation. You can also go to slightly lower temperatures than 41.8 degrees, and then we refer to this as a fever range. And you need to insulate the body, because the body will try to get rid of the excess heat in order to maintain this systemic temperature elevation. So the heating mechanisms used are mainly infrared radiation, and also very important is to realize that you can use 100% humidity near the patient in order to prevent the cooling mechanism of the patient to take action against this temperature rise. But the most commonly used method of heating is the infrared radiation, because if you rely on the second one, the metabolic heat, then it will take decidedly longer to reach the 41, 42 centigrade range. So some of the systems in use, Oncotherm, Irotherm, and actually most of these, or all of these, are using infrared radiation in some form. So advantages are that it is a more or less homogeneous temperature rise, but you still should be paying attention to some parts of the body where the elevation might be higher than intended. And the drawbacks are that, well, it has been studied quite extensively, and some studies show good palliative results for part of the patients, but the clinical benefit in general is a bit unclear, as it is, and it can be a very time-consuming procedure, so up to 6 hours if you go to the slightly lower temperature range of 40 degrees centigrade. And the patient burden and the burden for the staff can also be extensive with this type of treatment. So concluding for this part, most of the equipment currently in use is more or less site-dependent, which in a way is good, because there is no one-size-fits-all for hypothermia. And there is still some a drive to further improve equipment in order to be able to reach higher temperatures in the target regions. And at the same time keeping temperature elevation at other locations lower. So that is one driving force, but also some of the tumor sites, and there was already a question in the previous presentation, for instance for brain tumors, we need better equipment. We need improved thermal dose delivery, so that means not just the equipment to deliver, but also to monitor the temperature elevation. And a third category, and this is beyond clinical use, but also for the preclinical use, we can use better equipment to heat lab animals, because those are the best models, most reflecting what sort of mechanisms to expect within human patients. So for brain tumors, there are some applicators currently under development, usually with slightly higher frequencies and more antennas. So for the head, you can go to higher frequencies and still reach a good penetration depth. And this is an example currently developed in Sweden, using multi-frequency and multi-channel array of bow tie antennas. You could also go to an entirely different type of heating technique by going to scant focus ultrasound. The advantage of that is that the focal region is way smaller for ultrasound than for electromagnetic techniques. But there are some issues there in the sense that a number of anatomical structures can preferentially heat up, and that is limiting the number of locations where you can use this. So for instance, breast would be quite simple by comparison, and some pelvic tumors as well. And in this case, MRI can be used as a thermal monitoring system. Also, just mentioned is that for brain tumors, you could use magnetic nanoparticles. This has been tested for a number of locations, including brain tumors, where good therapeutic temperatures were demonstrated, and also indication that the clinical results were better than for other therapies. And there are a number of small animal devices under development. Most of these use a frequency of 2.5 gigahertz, because that is again a frequency which can be freely used without requiring a Faraday cage, and either single or multi-antenna systems. And the example shown here is a system currently under development by a manufacturer. So this was my summary of the hyperthermia equipment. Are there any questions from the audience?
Thank you for the nice summary. I only want to make some comments because I see that you have a lot of information from the microwave type of devices, but from the others maybe some information is missing. For example, I heard that there are whole body devices which are going up to 43 centigrade from Russia. I know some clinics who are going up to this temperature. I don't know how good it is or bad.
Yeah. If I can, just like the previous speaker, I think I answer per.
Okay.
Yeah, I know that I believe in Siberia they do the 43 degrees, I think, very briefly, and then continue on a lower. Otherwise, it would probably, and that's. I think they're using it against HIV mainly. And
in Germany, I know they are using against cancer. The time I don't know, but they are going up to 43, so more than 41.8.
Yeah.
By capacitive devices, depending on the matching algorithm, you can go through the fat layer without any problem burning, even deep-seated tumor, so it's not a big issue. I have to correct that you put up the Oncotherm whole body hyperthermia. It's not anymore existing, shown 20 years ago, so it's out.
I will remove it from.
Okay, so if you want to keep it, but it's obsolete now for many years.
Yeah.
From brain tumors, you are mentioning that it's now started. Brain tumor clinical data already exists already about 15 years ago. Some publication, of course, not randomized trials, but many publications showing that brain tumors can be treated with radiofrequency devices with good results.
Yes, I chose to include just a few, but I know about those as well. I will include them later on if there's a follow-up of the clinical data.
If you want, we can send also information on that. And veterinarian devices are also existing for preclinical studies already about 7 to 8 years ago. Mainly
I will include those as well. Yeah.
Okay, so these were my comments because these were somehow not up-to-date information which you had. Thank you very much.
Yeah, thank you.
Please don't look for this Siberian device because this doesn't exist. They use hyperthermic bars.
Okay. Timo, I think, has a comment or a question.
Hans, thank you for your, I'm not really surprised, excellent overview of this subject. I had a question about the isolated limb perfusion. You know, we worked on that. So you also suggest that hyperthermia is used there, but it's used at the same time as you give the chemo, and we saw that if you go too high, over 38, so actually it's not hyperthermia, you will have increased toxicity, you will have then a local problem. So could you comment on that? And the other one is for HYPEC. I'm not sure if that really has positive results with hyperthermia, whether that's an issue there. Could you elaborate on that also?
Well, there have been some, let's say, animal studies where they compared HYPEC, let's say, normothermic and hyperthermic, and they saw very interesting results there that indeed at the hyperthermic temperatures the drug distribution in the tumors, the target region increased a lot, and the strange thing is at the normal thermic use the systemic concentration of the drug increased, which was a very interesting result, and that was very, let's say, they repeated it over a large group of animals, and this was a very consistent result. So I think really that HYPEC works is probably a combination of perhaps a local better effect of the chemotherapy, that you get a better penetration in the cavity itself, on the surfaces where you apply it, as well as a still not perfectly understood physiological effect, which helps the distribution. So, whereas in patients, I do not believe that there are many studies where they did it normothermically, but I think there is still sufficient evidence that the hyperthermic temperatures really do help here, especially if you combine with the chemotherapy, where you know that the mechanism of action is, for instance, interfering with the DNA, causing DNA damage. That hyperthermia will prevent block repair of that damage. So, and that I think has also been demonstrated preclinically.
Yeah. So, and my question about isolated lymphofusion, when you have
Yeah.
chemo really at the same time as the hyperthermia, that we saw you actually have toxicity.
Yeah, I think that is dependent also on which drug you're using.
Either doxorubicin, the Italians, or melphalan like we did.
Yeah, maybe that is that could be an issue, because as far as I know, in preclinical studies, the timing was compared for a number of these drugs. And some drugs, it was better to first give the drug and then do the hyperthermia up to 24, 48 hours later, because then you would still see an enhancement of the activity in the tumor, whereas the toxicity would drop to non-existent levels. So maybe that is something which was an issue here.
Hans, here. Thank you for this excellent overview. You nicely mentioned that the development of the devices, it's also dependent on the location of the tumor. And what's your personal opinion is also taking into account how you heat it. So it's not only the heat, because it can be also the application. So meaning you might have some microwave effects, you might have some effects of electric fields. Is this taken into consideration for the new development? Also not just saying heating up the tumor, but also with which biological agent, let's say?
Okay. If I summarize your question, you were part of your question is, okay, do I take into account that there might be an additional effect of, for instance, using some forms of EM radiation? That has influence on the development, and it has no influence on the development of techniques. So in the sense that, in my opinion, there could be an additional effect of EM radiation, but that comes on top of the temperature effect. So you get that, let's say, so most of the techniques I've shown are EM based, so you get that effect on top of what you're already doing. So that means that you should still try to develop something which actually raises the temperature to the level you desire. If then that means that on top of that you get an additional effect, you're still really optimizing in that case. Because if you would settle for the, let's say, EM effect itself, the non-thermal effect or locally thermal effect or superlocally thermal effect itself, without actually raising the temperature, you would get possibly a therapeutic effect, but it would be way better if you also at the same time raise the temperature.
Thank you.
Okay.
Yeah, Hans, thank you. Very good presentation. I wondered, as you had addressed to some extent the temperature measurement techniques, I don't think you'd talked at all about the benefits of the non-invasive thermometry that integrates with some of these systems and the potential benefit that that could have currently as well as the future. Seemed like that might be appropriate for your comments.
Yeah. The topic of the presentation was actually the heating devices. So I thought, yeah, this was a sort of dilemma. How much will I say about measurement? And I decided I should say something about it, but not to go too much in depth to make it. But you were right. The integration of non-invasive measurement techniques is very important development and really helps, certainly at more challenging tumor locations. So, and currently the only technique that is really used routinely in clinically is of course the RD-MR thermometry techniques. Was that your question? Okay.
Thanks very much for this clear and close to complete overview about the heating devices. You didn't mention at all the planning part, because we want to know ahead of time, before we apply the heat treatment, what kind of heat we can achieve where. Maybe you can characterize the different devices where we have a planning available, where we are close to having a planning available, or where you believe it's not feasible to do a planning.
Yeah, my reply is actually almost similar to the remarks of Paul. Yeah, I could have included, of course, also the planning. But I can say in this case that, okay, planning, routine planning options are mainly available at this stage, I think, for the local, regional, deep heating using these arrays of antennas. And the reason is that if you use a single antenna on the skin, then you know what you can modify during treatment is the output power and maybe the temperature of your bolus water, and that's it. Whereas for a complex phased array of antennas, you really need to do the planning. And we have several different packages available at this moment, both commercial and in-house developed packages, and they are quite reliable in the sense that if the anatomy would be exactly the way you suggested in your input parameters, then you get a very accurate distribution. But we also know that during treatment there is a certain limitation to the reliability of your input parameters, your tissue properties, your perfusion levels, and they even change during treatment. So you also need during treatment, if you're using a local regional hyperthermia device like the BSD 2000 or the ALBA 4D, you really need treatment planning. And you not just pre-treatment, but also a form of adaptive planning during treatment. Otherwise, you cannot guarantee that you give a good treatment. And the more so because even if you're managing to elevate the temperature during treatment by just, let's say, a half a degree, this would actually amount to doubling your thermal dose. So this will make a difference. And also retrospective analysis of treatment temperatures, temperatures measured during treatment, thermal dose measured during treatment, and treatment outcome shows that there is a massive impact of the temperature level. So treatment planning is very important. But yes, I chose not to include that in this presentation.